Buenas noches, les estamos dando en este momento el acceso a la conferencia sobre miopía patológica que nos dará la doctora Kyoko Ohno-Matsui. Es un honor tenerlos acá con nosotros en esta noche académica de ACOREP. Es un honor tener a la doctora dándonos esta conferencia sobre un tema tan relevante en este momento para nuestra sociedad, como es el caso de la miopía patológica. Les agradezco profundamente su asistencia, nos honran a nosotros como ACOREP y además honran también la presencia de la doctora Kyoko. Doctor Carlos Mateo, un saludo muy especial desde ACOREP. Sabe que lo apreciamos muchísimo acá en Colombia y sabemos lo difícil que es conectarse para usted en este momento. Muchas gracias por estar aquí, doctor. Dr. Kyoko, it's a great honor, a privilege for us you be here. It's an honor that you take the time, and it's a pleasure to hear you about pathologic myopia. Hernan Goins, your presentation, please.
Yes.
Hi, good evening, everybody. Welcome all to this wonderful talk. I know everybody knows Dr. Kyoko, but even though I will give a briefly introduction, we all know that she is a professor and chair of ophthalmology at Tokyo Medical and Dental University, and also she's a director of the Advanced Clinical Center for Myopia. Also, she is a world-renowned expert in pathological myopia. We all know that. And she has contributed to develop the International Photographic Classification of Myopic Maculopathy, and also a pioneer on the 3D MRI imaging of the eye. And of course, she has written down about 500 papers on different index journals. And of course, we cannot forget that Dr. Kyoko is the recipient of the Duke Elder Medal in 2025, also the Retinal Lecture Award in 2024, and the Jose Rizal Medal in 2023. And the last but not least, the J. Donald Gass Medal in 2022. So tonight we have the privilege to see the topic given by Dr. Kyoko, named Retinal Complications Related to Myopia. And before she can begin, all of you have to remember that if you have any questions, you can write them down in the Q&A box, and I will address at the end of the conference if we have time enough to do it. So, Dr. Kyoko, now the stage is yours and also the audience. Welcome.
Thank you very much for a great introduction, and thank you very much for inviting me to this great meeting. I'm so happy to meet all of you and also my friends. So thank you very much. I'm going to start my presentation. Can you see my screen?
Yes.
Okay.
We are seeing.
Yes. Yeah. Thank you so much. And I'd like to start with a general explanation of myopia. As you know, the prevalence of myopia has been increasing worldwide. If the current trend continues, by 2050, half of the entire population in the world will become myopic, and 10% of the world population will become highly myopic. And according to the International Myopia Institute, pathologic myopia is mainly defined by the presence of myopic maculopathy equal to or more serious than diffuse atrophy or having posterior staphloma. Most of myopic patients maintain good corrected vision, but pathologic myopia is a major cause of blindness worldwide, especially in East Asian countries. Then, what causes the blindness in pathologic myopia? There are three major causes: myopic maculopathy, myopic traction maculopathy, and glaucoma or myopic optic neuropathy. And the cause of developing the above complications is eye deformity characterized by posterior staphyloma. First, myopic maculopathy. According to the Meta-PM study group, myopic maculopathy was classified into 5 categories: 0, no maculopathy; 1, tessellated fundus; 2, diffuse atrophy; 3, patchy atrophy; and 4, macular atrophy. Other lesions like lacquer cracks and neovascularization are categorized as plus lesions. Because category 0 and 1 are not specific to pathologic myopia, here I simplify it to category 2, 3, and 4 alone. Next, I will provide an overview of what is happening in each lesion. First, category 2, diffuse atrophy. This lesion is characterized by the extreme thinning of the choroid. Almost the entire choroid disappears, besides sporadically remaining large choroidal vessels. Despite the extreme choroidal thinning, the outer retina and RPE is well maintained, and patients generally show sufficient vision. Then, category 3, patchy atrophy, and category 4, macular atrophy. They are both well-defined whitish lesions, but the location is different. Patchy atrophy is seen outside the fovea, and macular atrophy is fovea-centered. OCT shows that both lesions are not simply an atrophy, but are characterized by Bruch's membrane defects. Differences in location between patchy atrophy and macular atrophy continue even when the lesions keep enlarging. Patchy atrophy occurs outside the fovea, and even when it enlarges, it doesn't affect the fovea. So central vision is usually maintained. This also shows that macular atrophy is not a progression from patchy atrophy. Actually, macular atrophy almost always occurs around the neovascularization. Macular atrophy is caused by an enlargement of Bruch's membrane hole around the neovascularization. And it is macular atrophy that impairs central vision. Considering this, myopic maculopathy may have 2 separate progressive patterns. One is from diffuse atrophy to patchy atrophy. In this case, Bruch's membrane holes develop outside the fovea, and the central vision is maintained. The second pattern is macular atrophy, development from myopic neovascularization. In this case, Bruch's membrane holes enlarges at around the fovea, and central vision loss occurs. This shows that the central vision loss in highly myopic patients is mainly caused by neovascularization and its consequence, macular atrophy. Next, myopic traction maculopathy. Myopic macular retinoschisis is observed in 9 to 30% of highly myopic eyes and can progress to serious complications like macular hole RD in a natural course. Several causes are identified for development of retinoschisis. Tensile forces include the inner limiting membrane, posterior staphyloma, and axial elongation. In contrast, tractional forces are primarily attributed to vitreous traction. Among them, vitreous traction may be the most important. I will show you why. I will show you some examples. As we know, the vitreous in highly myopic eyes is often pathological. Multiple and multi-layered PVDs are more commonly observed. In this patient with macular retinoschisis, the posterior vitreous appears thickened, and vitreous cortex is firmly adhered to the inner surface of the retina at multiple points. Close observation reveals that the borders of the multiple PVDs correspond to the location of retinal vessels, as indicated by red arrowheads. Vitreous adhesions at multiple points of retinal vessels are well observed in this movie. It shows an entire figure of starfish-shaped partial PVDs. To identify the underlying cause, multiple scans may be necessary, even with the use of wide-field OCT. For example, in this patient with macular retinoschisis, a horizontal OCT image reveals the edge of the staphloma, and the retinoschisis is confined within the macula. The posterior vitreous is detached from the inner retinal surface within the staphloma, but vitreous adhesion to the fovea is also observed. Based solely on this image, one might conclude that the retinoschisis of this patient is caused by foveal traction. However, an adjacent OCT image shows that 3 retinal vessels are lifted. Outer retinoschisis is more severe around these vessels compared to the foveal area. Inner and middle layer schisis are also seen around these vessels. An oblique OCT section shows that posterior vitreous adheres to the inner retinal surface at the site of these vessels. Multi-layered schisis is observed around the retinal vessels, with the outer schisis extending from the area surrounding the vessels toward the fovea. Such vascular traction may not be apparent on conventional 6 mm scans or even cross-sectional scans with a wide-field OCT. However, radial scans using wide-field OCT can effectively identify vitreous traction on retinal vessels. In this case with retinoschisis, the posterior vitreous is thickened, and there is a single vertical strand connecting the posterior vitreous to our retinal vessels. Outer schisis is prominent around the vessels. And in this 3D movie, you can see numerous strands connecting the posterior vitreous surface and retinal vessels. This image shows how strong the vitreous adhesion to retinal vessels is in pathologic myopia, especially with retinoschisis. And analyzing multiple B scans with wide-field OCT is essential to identify the underlying cause of retinoschisis. And in this patient as well, vitreous traction on the papillary and peripapillary retina is evident. A staphyloma edge and ILM detachment are also observed, suggesting that these factors may contribute to the development of retinoschisis of this patient. However, an oblique section clearly shows strong vitreous adhesion to the retina between these 2 vessels indicated by arrows. In this region, multi-layered schisis and paravascular cystic spaces are observed. The outer retinoschisis extends from this area toward the macula. And in this case as well, retinoschisis is visible on this horizontal scan. Partial PVD is also observed. However, on the vertical scan, vitreous adhesion is observed in the area upward to the fovea. In the magnified image, 2 retinal vessels protrude anteriorly, and the vitreous is adherent around these vessels. Retinoschisis is the most prominent around these vessels, with multi-layered schisis observed. This is another case. On the horizontal scan, retinoschisis is observed nasal to the fovea. A staphyloma edge is visible in the temporal fundus. Vitreous adhesion is seen in the area slightly inferior to the optic disc. On the vertical scan, the vitreous is adherent at multiple points. The arrows indicate retinal vessels, around which vitreous adhesion is particularly strong. Along the superior retinal vascular arcade, outer retinoschisis is the most prominent and is accompanied by multi-layered schisis. This is an oblique scan. Strong vitreous adhesion is seen along both the upper and lower vascular arcades. retinoschisis and multi-layered schisis are present around these vessels. On AMPHA's image, paravascular retinal detachment appears as hyporefractive areas, as shown in the left image. In the left image, retinal arteries are straightened toward the optic disc, and multiple hyporeflective areas are observed along these two arteries. On the OCT image, these arteries protrude anteriorly. In addition to paravascular retinoschisis, retinal detachment is present at the site of these arteries. These findings suggest an important role of retinal arteries in the development of traction maculopathy, and AMPHA's imaging clearly demonstrates mechanical changes in and around these retinal arteries. In this OCT image, the structures indicated are retinal vessels. In addition to retinoschisis around the vessels, a paravascular lamellar hole is also observed. Actually, Shimada reported that in approximately 80% of eyes with macular retinoschisis, paravascular lamellar holes were present, and the retinoschisis extended from these paravascular lamellar holes toward the foveal region. These findings also suggest the important role of paravascular abnormalities in the development of macular retinoschisis. And Takahashi and colleagues compared highly myopic eyes with and without retinoschisis and found vitreous adhesions to retinal vessels more frequently in eyes with retinoschisis. In contrast, adhesion to the fovea did not significantly differ between groups, and paravascular abnormalities such as retinosis, retinoschisis, and lamellar holes were more common in eyes with retinoschisis. And multivariate analysis identified paravascular vitreous adhesions as a significant predictor for the development of retinoschisis. And vitrectomy with modified IOM peeling is considered the standard surgical approach. And with this technique, the risk of developing full-thickness macular hole is nearly eliminated, and the retina gradually reattaches over time. And while macular buckling has been performed in some cases, it may carry some risks such as exacerbating mechanical damage to the optic nerve. It is similar to pressing a balloon with fingers. When one area is pressed, the surrounding regions bulge outward more prominently. In this case, the surrounding area includes the optic nerve, and so and it is also important to remember that the optic nerve is an important cause of visual impairment in high myopes. Additionally, macular buckling does not address the root cause of traction maculopathy, which lies in vascular traction outside the macula. Although this is retinal conference, I like to briefly mention optic nerve damage and glaucoma because this is an important complication to think about the treatment of high myopes. Optic nerve damage is often overlooked or underdiagnosed until it reaches an advanced stage. For example, this 60-year-old woman with an IOP of 11 and had a vision of 0.02, and she repeatedly complained of decreased vision. But she was consistently told that her vision impairment was due to macular atrophy, shown in the left image. And by the time she visited us, her visual field had deteriorated significantly, as shown here. And many patients are underdiagnosed and being told their vision loss is caused by retinal complications. And this is a 30-year-old man with an IOP of 10 and vision of 0.1. And he also complained decreased vision repeatedly, but he was told his symptoms was due to diffuse choroidal atrophy. And his optic disc already looks pale. And by the time he visited us, his visual field had already deteriorated to this extent. And it is important to note that myopic maculopathy and myopic traction maculopathy does not cause the loss of the outermost isopter in the Goldmann visual field. Therefore, we usually use the outermost isopter as a key parameter to indicate optic nerve damage. And for this patient, we performed multiple surgeries, but in several years, he completely lost his sight. Then, why the diagnosis of the optic nerve damage is difficult in pathologic myopia? Because the optic nerve is deformed and making it challenging to suspect glaucoma based on optic disc appearance alone. And due to myopic maculopathy or large PPA, Humphrey visual field analyzer results are often unreliable. And interpreting the nerve fiber layer thickness map and the ganglion cell complex map can also be difficult. So we suspect optic nerve damage during stereoscopic observation with 90D lens and perform Goldmann visual field testing periodically, at least once a year. And pathologic myopia presents unique causative lesions, one of which is corner spits. In this case, while the optic disc appears tilted, the fundus photo alone does not clearly indicate visual field defects. However, a horizontal OCT scan reveals a complete peripapillary scleral defect. The overlying retina is herniated into the scleral defect and significantly thinned over the pit. In some cases, multiple corner spits can be observed. In this example, in Alpha's image, revealed several pits, while OCT scans show full thickness of scleral defects, along with the thinning of the overlying retina. As corner pits almost always occur temporal to the optic disc, they damage the papillomacular nerve fiber bundle, leading to the central vision loss. And the other lesions are commonly associated with non-highly myopic glaucoma. The most representative one is laminar cribrosa defect. However, in highly myopic eyes, these defects are typically larger and deeper. In this case, a significant laminar defect is evident along the temporal border of the optic nerve, accompanied by projection of the lamina from the lamina. The overlying retina is notably thinned here, and routine OCT examinations of the optic nerve frequently reveal laminar cribrosa defects. But visual field defects only occur when the overlying retina is compromised. Even in this patient, she has large laminar defects, but the overlying retina is intact. In this case, visual field is not impaired. But over time, the overlying retina becomes thinned, resulting in a paracentral scotoma in the visual field. And when the overlying retina is completely lost, it causes absolute scotoma. So the width or depth of laminar defects is not the primary factor causing visual field defects. There are many highly myopic patients with laminar defects, but it is the thinning or loss of the retina overlying the laminar defects that leads to these issues. Actually, diagnosing glaucoma is very challenging in high myopes. So when should we suspect visual field defects in patients with pathologic myopia? I think if at least one of these lesions is observed, Goldmann visual field testing should be considered. One is large or small optic disc. Visual field defects are frequently associated with these different disc sizes. And scleral ridge. This ridge, seen as a protrusion of a sclera temporal to the optic disc, stretches and thins the overlying retina. And corner spits also tend to form on the ridge, on the slope of the ridge. And deformed optic disc, particularly when the disc appearance is asymmetrical, areas of the lamina may be disproportionately stretched. and intracorridor cavitation, which is a yellow lesion, and often located lower to the optic disc. And ICC itself does not cause visual field defect. However, a retinal defect may develop along the margin of the ICC, damaging the overlying nerve fiber layer. So we can pay close attention to these 4 abnormalities, as they may indicate potential visual field defects. So finally, I would like to move on to posterior staphloma, because it's a cause of complications. It's a outpouching of the wall of the eye and hallmark lesion of pathologic myopia. Actually, Dr. Curtin emphasized the importance of staphloma in defining pathologic myopia 50 years ago. Based on many of his observations, he suggested that it is apparent that the refractions and axial lengths are unreliable indicators of even the very diagnosis of physiologic or pathologic myopia. The morphology of staphloma would be a much more reliable basis. Emmetropic eyes become myopic by axial elongation, and this axial elongation mainly occurs in the equator of the eye. When I joined the high myopia clinic, I thought that staphloma formation was just a continuum of axial elongation, even though the affected area was posterior pole, which was different from an elongation of the equator of the eye. However, in 3D MRI images of the eye with deep staphloma, the eye wall outside the staphloma often flattens. This is our New Year favorite, rice cake. When it is baked, it uniformly swells at first. But once the central part pops out, the surrounding area becomes flattened. So the similar thing may happen to staphloma development. So staphloma formation is a drastic change of the eye shape and is a different phenomenon from axial elongation. And 3D MRI enables to show the entire shape of the eye in 3-dimensional way from any angle. Emmetropic eyes are completely spherical, but the eyes with pathologic myopia are not simply elongated, but severely deformed. And the pattern of eye deformity is different among patients. The most common type of staphloma is the wide macular staphloma, which is seen almost in half of highly myopic eyes. In Optus image, the border of staphloma was seen as pigmented or depigmented lines. 3D MRI images show a protrusion of wide area of the posterior segment in the images viewed from nasally, inferiorly, and from the back. The upper and temporal border tended to be abrupt, and there was a notch along the upper and temporal border of staphloma. The protrusion is horizontally wide in the images from the back. The most protruded point existed along the central visual axis in the half of the patients, but lower to the central axis in the other half. So the lower part of the eye tends to expand more than the upper part. And overall, wide staphloma is deep and narrow staphloma is shallow. And now we use wide field OCT, which was a prototype by Canon, but we now use a Dream OCT. I show a representative case with staphloma. In the Optus image, the upper edge of staphloma is seen by arrowheads, and 3D MR images show a wide macular staphloma. And in B-scan or wide field OCT, the staphylomatous region shows a posterior displacement of the sclera. Staphloma edge shows consistent features with gradual thinning of the choroid from the periphery toward the staphloma edge and a gradual thickening toward the posterior pole. And staphloma was considered to develop in later age, but it was not certain at what age staphloma developed. And wide field OCT showed that staplomas developed at much younger age than we had thought. This is an 8-year-old girl with axial length of 26 millimeters. At baseline, the inner scleral curvature is inclined toward the optic disc, and no staphloma edge is seen. 3 years later, the axial length increased by 1 millimeter. Scleral inward protrusion, suggesting a cephaloma edge, is formed nasal to the optic disc. And the macula sclera bows more posteriorly, and the curvature and the fovea is now centered, is at the deepest point. And this is an 11-year-old girl. Mild cephaloma is already seen at baseline. 4 years later, in addition to pre-existing nasal edge, a new edge is formed temporal to the optic disc. In parallel, the sclera is bowed more posteriorly, with its deepest point shifted temporal to the fovea, and the inner scleral curvature has changed symmetrical around the fovea to asymmetrical around the fovea, and fovea is shifted nasally. And this shift of fovea may explain the very little increase of the axial length. So we can differentiate pathologic myopia from physiologic myopia in childhood. So I think it is important information to differentially manage pathologic myopia and physiologic myopia even in children. So in summary, myopic maculopathy is characterized by extreme thinning of the choroid and Bruch's membrane defects. Bruch's membrane defects occurring in the fovea, which is myopic neovascularization and macular atrophy, impairs the central vision. Vitreous traction on retinal vessels may play a significant role in the development of traction maculopathy. Glaucoma and optic nerve damage are often overlooked in patients with pathologic myopia, sometimes only being detected at advanced stages. Posterior cephaloma is an important feature to differentiate pathologic myopia from physiologic myopia. Wide field OCT can detect cephaloma edges even in children. Therapies targeting cephalomas before developing blinding complications are expected. Again, thank you very much for your kind invitation, and I would appreciate your questions and comments.
Thank you very much, Dr. Kyoko, for your excellent conference. It helped us to improve the understanding of pathological myopia. And we have some questions. Please, Hernan.
Okay, thank you, Dr. Kyoko. So we have the first question from Dr. Alberto Castro. He's asking what do you think is the role of a scleral buckle in retinal detachment associated with pathological myopia?
Yeah, this is a very important question. Thank you so much. I think this scleral buckle means macular buckling. So we used to or peripheral scleral buckling or macular buckling. I think this means macular buckling.
I think it's writing scleral buckling.
Oh, peripheral. I see.
Yes, peripheral.
Peripheral. Oh, thank you so much. Yeah, we still do. We still conduct a peripheral scleral buckling for patients with pathologic myopia. But interestingly, in patients with pathologic myopia, a peripheral retinal detachment is not common. It is probably because the peripheral retina has already degeneration, and so some pathological adhesion exists in peripheral retina. So we very rarely see usual peripheral retinal detachment in patients with pathologic myopia. Instead, we see many macular hole retinal detachment or foveal retinal detachment. But in the case if they develop scleral peripheral retinal detachment, we also do conduct peripheral buckling too.
Great. Okay, and I think we can move on to the second question, which is also from Dr. Alberto Castro. And he's asking, what is the role of IOP control in the progression of pathological myopia?
Yeah, thank you very much for this important question too. And I think there was a clinical trial to show the effectiveness of IOP lowering drug to decrease axial length elongation. But I'm not sure about the result. But pathologic myopia is often caused by genetic things, so it may be difficult to prevent the pathologic myopia by lowering IOP. But in the end, many patients develop glaucoma or optic nerve damage. So in our high myopia clinic, I think we prescribe IOP lowering drugs in more than half of the patients. So I'm not sure if it is beneficial for axial length elongation or preventing macular complications, but maybe useful to prevent glaucoma or optic nerve damage because it is often underdiagnosed. So I'm not sure, the answer is I'm not sure if IOP control is useful for decrease the progression of pathologic myopia, but it may be beneficial for future glaucoma or current glaucoma.
Okay, thank you, doctor. And this is another question. Is just write it down in the Q&A box. He says that does treatment with low dose atropine reduce the risk of developing staphylomas and alterations in the collagen lamella?
Yeah, thank you so much. And actually, I think it may be difficult. And recently, we conduct Caroline Klaver from the Netherlands previously conducted gene analysis of highly myopic patients, and she showed that even in simple.
Oh, so sorry. If there is anyone with the mic open, please close it. Sorry, doctor, you can continue.
Yeah. Thank you so much. Actually, this low dose atropine may be difficult to work because Caroline Klaver from the Netherlands conducted gene analysis for simple high myopia patients, and she showed that even in simple high myopia, 20% of them had syndromic genes, and the most common one was retinitis pigmentosa. And we also conducted gene analysis for our patients with pathologic myopia, and at least 10% of them were a female carrier of Alport syndrome. So I think a significant portion of pathologic myopia may be genetically related. So in that sense, I think it is different from usual childhood myopia. So and also the area affected in pathologic myopia is a posterior pole, and which is different from equator, the enlargement of the equator in usual myopia. So I'm not sure if low dose atropine works, but it is less likely, I guess.
Okay, great. I think it's coming out a lot of questions. Let's see how many others can we do it. Let's go with this one. What do you think, doctor, about the scleral cross-linking to prevent the progression of myopia?
Yeah, thank you so much. I think it is useful, and scleral cross-linking can stiffen the sclera and maybe may prevent the resist to the axial elongation. So I think it's a useful approach, and it is widely conducted for keratoconus. And actually, we were supposed to start clinical trial 2 or 3 years ago, but the company decided it would not be profit. So it was suspended. So, but I think if you have any help from pharmaceutical industries, I think it is very useful option.
Okay, great.
Thank you very much, Dr. Kyoko. Dr. Carlos Mateo, would you like to ask something to Dr. Kyoko?
Yeah, of course, Kyoko. Well,
thank you.
Good
Nice
morning
to see
here in Barcelona. It's 2 in the morning, and you have to be later. I have 3 questions, very important for me. One is dome shape, because we never think about dome shape because we don't have treatment about dome shape, and I want to know your idea about what is the cause of dome shape and any insight in treatment.
Yeah, actually, dome-shaped macula treatment is very difficult when serous retinal detachment occurs on the top of the dome. So we don't have any useful treatment. So usually we observe, we follow up. But sometimes when we perform fluorescent angiography, some patients show dye leakage from the pinpoint, and so I think maybe periodical fluorescent angiogram is also necessary. And if we see that, we apply laser. But otherwise, anti-VEGF or steroid, not other treatments are not effective. So if there is no dye leakage, we just observe. Yes.
Yeah, great. And there's another two questions. One important thing, a paper you wrote some years ago, is about how some of these patients that have macular hole in the posterior staphylococcus, these high myopes, develop macular atrophy after the surgery. And I think many surgeons, they have to know about it, because you operate on myopic macular hole, and you suddenly you see how it appears macular atrophy. You know any insight about this?
Yeah, thank you very much for reading that paper. Yeah, actually, this finding was found by one of my PhD candidates, and yes, I had thought that macular atrophy almost always occurred from neovascularization, but there was another macular atrophy occurring after a vitrectomy, and when we retrospectively analyzed the images, the tiny Brooks membrane hole occurs right after the surgery. So probably in the very fragile retina and Brooks membrane. And of course, we do a foveal sparing ion peeling, and we try not to put attraction. We not put attraction to the fovea, but a tiny Brooks membrane hole occurs in some patients. And over time, in such an axially elongated eyes, this Brooks membrane hole enlarges and becomes macular atrophy. So usually we don't see follow-ups such a long time, the patients who are treated by vitrectomy, but I think it's one of a long-term condition, and I think it's probably related to intraoperative traction to Brooks membrane.
Great. And my last question, when we operate, macular traction maculopathies with the foveal detachment or whatever, and we don't have any macular hole. You mentioned these inner holes that you have around the vessels. This is very interesting topic. But when you don't have any hole, my question to you is, do we have to use gas to tamponade? Well, tamponade means you have a hole. Many papers said, tamponade. Because Akiro Irakata from Japan, they mentioned in a series of 6 cases, he mentioned 2 macular holes after the surgery. And he mentioned the possibility to be the gas, the main cause of these macular holes, making pressure in the upper part of the foveal detachment and low pressure in the down. Then you recommend to use gas in these only macular traction maculopathies with no holes?
Yeah, thank you so much. Only for macular traction maculopathy without holes. Actually, we don't use gas. And actually, when we use gas, it may be useful to press the retina to the original place, but the retina is very stretched and thin, and we sometimes see extrafoveal new retinal holes after vitrectomy with gas. So too much pressure and too rapid pressure may be harmful. So we don't usually use gas, and so that the retina gradually returns to the original place. So yes, I'm against gas.
Great, Kyoto. Thank you very much. It's a very great topic. Great topic.
Thank you very much for wonderful questions. Thank you.
Okay, thank you, Dr. Carlo Matteo, for that interesting discussion. Thank you, Dr. Kyoko. I think I'm sorry with the other people that has all those questions, but the time is arriving to the end. So on behalf of ACOREF, Dr. Kyoko, I want to thank you for being here and for this amazing and outstanding talk. We hope to have you again here in the future. Thank you. Thank you very much.
Thank you very much for having me. I was very pleased to be here and to see Carlos, Marcio, and many of my friends here. Thank you very much.
Okay.
Thank you,
Thank you
Kyoko.
very much, doctor. Thank you.
Bye to all. Bye bye.
Bye bye.
Les agradecemos mucho su presencia en esta conferencia. La doctora Kyoko se encuentra en Japón, jornada laboral y amablemente nos dedicó este tiempo y debe pues como continuar con su jornada. En otra ocasión esperamos contar con ella y poderle extender estas cuestiones. Muchas gracias a todos por toda su asistencia, especialmente a la doctora Kyoko, y esperamos verlos pronto en las próximas reuniones académicas. Muchas gracias.